everyone. We are Group 4 and we are going to report about chronic obstructive pulmonary disease or the COPD. Our report is divided into 6 parts. We will start with the case presentation, followed by introduction, pathophysiology, clinical presentation, treatment, and related information. For our case, our patient is a 63-year-old retired astronomer who has been smoking since she was 18 years old. She is having trouble for years, but she has not been willing to quit just yet. Additionally, she has noticed a mild, occasionally productive cough for the past 3 to 4 months, and the cough is worse whenever she spends the night out in the country taking astrophotos where she is exposed to the smoke of the nearby wildfires. She finally decided to visit her family physician, who, after making appropriate patient-centered inquiries as to how her astrophotography hobby is going, finds that she has been smoking about 1 pack per day for the past 45 years. The cough has been present for almost a year, but she had no fevers or chills. She does admit to more shortness of breath when she exercises over the past 6 months, and her only past medication history includes hypertension, for which she is using lisinopril, metoprolol, and hydrochlorothiazide. For the appropriate diagnostic procedure, if a patient is suspected of having COPD, chest X-ray and spirometry are the most appropriate initial diagnostic measures. A chest X-ray would be a reasonable study to look for masses, infiltrates, edema, or signs of obstructive airflow suggestive of COPD. However, a normal chest X-ray does not rule out COPD. And unless contraindicated, such as if the patient has unknown active tuberculosis or unknown origin of hemoptysis, recent myocardial infarction, or unstable angina, spirometry should always be obtained to evaluate any patient suspected of COPD, as spirometry is the gold standard for diagnosing COPD and assessing its severity. For the result interpretation, the patient showed a normal chest X-ray, and her spirometry was an FEV1, or the forced expiratory volume of 85% of the predicted, and an FEV1 over FVC of 65%. FVC, or forced vital capacity, is the largest amount of air you can breathe out after breathing in as deeply as you can, while the FEV1, or the forced expiratory volume, shows how much air you can exhale from your lungs in 1 second. So according to the gold standard, or the Global Initiative for Chronic Obstructive Lung Disease, FEV1 results are used to stage the COPD. So stage 1, or mild, if the FEV1 is greater than or equal to 80%, stage 2, or moderate, if the FEV1 is 50 to 79%, stage 3, or severe, if FEV1 is 30 to 49%, and stage 4, very severe, if the FEV1 is less than or equal to 30%. And if the FEV1 or FVC is less than 70%, the patient is diagnosed with COPD. Our patient has mild COPD as she has an FEV1 of 85% and an FEV1 over FVC of 65%. Management and treatment. Since the patient has mild COPD, slowing the progression and improving her symptom would be the best option. So the patient was started with varenicline at the visit, and counseling was done. Counseling for tobacco cessation along with initiation of a pharmacologic agent to assist in quitting has shown proven benefit. In this case, varenicline, also known as the Chantix, is a prescribed medication used to treat nicotine addiction. It reduces craving for and decreases the pleasurable effects of cigarettes or other tobacco products. It would not be wrong to prescribe a short-acting inhaled beta agonist to help control symptoms. However, her symptoms are mild and she would not likely receive significant benefit from an inhaler at this stage. For the medications management, the patient can continue with her medications and no necessary changes should be made. For the rationale, beta blockers, ACE inhibitors, and thiazide diuretics are safe and may be used in most patients with COPD. While physicians are often worried about using beta blockers in patients with COPD because of concerns that they may worsen bronchoconstriction, the use of cardioselective beta blockers has not shown to worsen FEV1, COPD symptoms, or responsiveness to inhaled beta agonist. And the patient is using metoprolol, which is a cardioselective beta blocker. This patient also has a productive cough, as well as a history of tobacco smoking and spirometry consistent with mild COPD as the cause of her cough, so she does not need to discontinue her ACE inhibitor. And thiazide diuretics are cheap, safe, and have been proven to be effective against for the treatment of hypertension, as well as being associated with improved cardiac outcomes. So no indication to stop using diuretics is also present.
For the introduction of chronic obstructive pulmonary disease, or abbreviated as COPD, it is a common lung disease characterized by airflow limitation that is not fully reversible. It is both chronic and progressive and is associated with an abnormal inflammatory response of the lungs to anxious particles or gases. In contrast to the reversibility of airflow limitation in asthma, COPD is not fully reversible. Next will be the pathophysiology of COPD. It results from the combination processes of peripheral airway inflammation and narrowing of airway. This leads to airflow limitation and destruction and loss of alveoli, terminal bronchioles, and surrounding capillary vessels and tissues, which adds to airflow limitation and leads to decreased gas transfer capacity. The primary cause of COPD is cigarette smoking. Other risk includes a genetic predisposition, impaired lung growth, airway hyperresponsiveness, environmental exposure including occupational dust and chemical and air pollution. Next, next is COPD is differentiated from asthma. In that the airflow limitation present is not fully reversible. It is helpful to differentiate inflammation occurring in COPD from present in asthma because the response to inflammatory therapy is different. The inflammatory cell that predominates differ between two conditions, with neutrophil playing a major role in COPD, while in asthma is eosinophil and mast cell. Next will be the etiology of airflow limitation in COPD. For reversible COPD, presence of mucus and inflammatory cell and medicator in bronchial secretion, bronchial smooth muscle contraction in peripheral and central airway, dynamic hyperinflation during exercise. While in irreversible COPD, fibrosis and narrowing of airway, reduced elastic recoil with loss of alveolar surface area, and destruction of alveolar support with reduced patency and small airway. For the clinical presentation of all patients with COPD have reduced flow rate or forced exhalation. Patients with mild, moderate, and severe COPD are characterized to have cardinal symptoms. They have chronic cough, sputum production, dyspnea, history of exposure to the risk factor. For the clinical examination, they shows um, cyanosis of mucosal membrane, barrel chest, as you can see in the picture, swallow breathing, increased respiratory rate, pursued lips during expiration, and use of accessory respiratory muscles. For the diagnostic test, spirometry, which is a gold standard for COPD. For the hallmark of COPD, FEV1, FVC ratio is less than 70%. There which means there is an airway obstruction. Other diagnostic tests includes radiograph of chest and atrial blood gas. Mm, Patients who have COPD have decreased FEV1 and FEV1 FVC ratio. Um, for the classification of COPD, results are interpreted in four stages. Next slide. For stage one, patients who have mild symptoms or diagnosed as mild COPD have FEV1 result of 80% or equal to 80%. For stage two, um, with a moderate COPD, FEV1 is equal to 50 to 79%. Stage 3 with severe COPD, FEV1 is 30 to 49%, and stage 4 with very severe FEV1 is less than or equal to 30%.
For the fifth section of this report, we are going to tackle the treatment. But before that, let's define the desired outcome for COPD. Limiting or eliminating exposure to tobacco, smoke, and other environmental irritants should be the goal of prevention efforts. For patients already with a diagnosis of COPD, the primary goal is to prevent or slow disease progression. Goals of COPD management includes prevent disease progression, relieve symptoms, improve exercise tolerance, improve overall health status, prevent and treat exacerbations, prevent and treat complications, reduce morbidity and mortality. The approach for the treatment to be effective, clinicians should address four major components of management. These are assess and monitor the condition, avoid or reduce exposure to risk factors, manage stable disease, and treat exacerbations. Non pharmacologic options, it will always be smoking cessation. Smoking cessation leads to decreased symptomatology and slows the rate of decline of pulmonary function even after significant abnormalities in pulmonary function tests have been detected. The USPHS guidelines recommend that clinicians take a comprehensive approach to smoking cessation counseling. Advice should be given to smokers even if they have no symptoms of smoking related disease or if they are receiving care for reasons unrelated to smoking. Here are 5-step strategy for smoking cessation program. We have the ask, advise, assess, assist, arrange. Ask, use systematic approach to identify all tobacco users. Advise, urge all tobacco users to quit. Assess, determine willingness to make cessation attempt. Assist, provide support for the patient to quit smoking. Arrange, schedule follow-up and monitor for continued abstinence. So this is the table for the first-line pharmacotherapies for smoking cessation. We have the agents bupropion SR, nicotine gum, nicotine inhaler, nicotine nasal spray, nicotine patches, and varenicline. So just take a look for the usual doses of each agent for the duration and take note of common complaints. Pulmonary rehabilitation is also a non-pharmacologic option. Pulmonary rehabilitation has direct effect on lung function or gas exchange. Instead, it optimizes other body systems so that impact of poor lung function is minimized. Exercise training reduces the CNS response to dyspnea, ameliorates anxiety and depression, reduces thoracic hyperinflation, and improves skeletal muscle function. Studies have demonstrated that pulmonary rehabilitation with exercise 3 to 7 times per week can produce long term improvement in activities of daily living, quality of life, exercise tolerance, and dyspnea for patients with moderate to severe COPD. Long-term oxygen therapy, this is use of supplemental oxygen, which increases survival in COPD patients with chronic hypoxemia at rest. Before patients are considered for long-term oxygen therapy, take note that they should be stabilized in the outpatient setting and pharmacotherapy should be optimized. Once optimized, long-term oxygen therapy should be instituted if either of the following two conditions is observed and documented twice in a 3-week period. First, um, a resting PaO2 of less than 55 millimeter mercury, which is 7.3 kPa, or SaO2 less than 88%, within or without hypercapnia. Second, a resting of PaO2 between 55 and 60 millimeter mercury, 7.3 and 8.0 kPa, or SaO2 less than 88%, with evidence of right-sided heart failure, polycythemia, or pulmonary hypertension. So the most practical means of administering long-term oxygen is with the nasal cannula at 1 to 2 liter per minute, providing 24% to 28% fraction of inspired oxygen with a goal to raise above 60 millimeter mercury, which is 8 kPa. Another non-pharmacologic option is the immunizations. It is recommended so that we can reduce the likelihood of respiratory infections that lead to COPD exacerbations. An actual vaccination with inactivated intramuscular influenza vaccine is recommended. Current GOLD guidelines recommend immunization with PPSV23 for all COPD patients who are 65 years and older, and for patients less than 65 years with comorbidities or FEV1 less than 40% predicted. Committee on Immunization Practices recommend vaccination with the 13-valent pneumococcal conjugate vaccine for all adults aged 65 years or older. At age 65, it is recommended to administer PCV13 followed in 1 year with PPSV23 as long as at least 5 years have passed since the previous PPSV23.
So for pharmacologic options, the primary goal of pharmacotherapy is to improve patient symptoms, reduce the frequency and severity of exacerbations, and improve the patient's exercise tolerance. First is we have bronchodilators. There are two types of bronchodilators. First one is short-acting, then under this are SABA and SAMA. We'll go through this later. For short-acting bronchodilators, this is the initial recommended therapy for COPD patients who experience occasional symptoms or under category A. These are also recommended for all patients for use as rescue or as needed therapy to manage symptoms or under category A, B, C, and D. These have a relatively rapid onset of action, relieve symptoms, and improve exercise tolerance and lung function. So under short-acting bronchodilators, you have SABA and SAMA. SABA, or also known as short-acting beta-2 agonists, this stimulates adenyl cyclase to increase formation of cyclic adenosine monophosphate, which is responsible for mediating relaxation of bronchial smooth muscle. Beta-2 agonists may improve mucociliary clearance within the airways, cause only a small improvement of FEV1 acutely, but may improve respiratory symptoms and exercise tolerance despite a small improvement in spirometric measurements. And for SAMA, or short-acting muscarinic antagonists, this produces bronchodilation by competitively inhibiting muscarinic receptors subtypes M1, M2, and M3 in bronchial smooth muscle and mucous glands. This also blocks acetylcholine to constrict bronchial smooth muscle and decrease mucus secretion. Ipratropium is the most commonly prescribed short-acting anticholinergic agent for COPD in the United States. The next type of bronchodilator is long-acting. This is for patients with COPD who experience persistent symptoms or in whom short-acting therapies do not provide adequate relief. These are also recommended for patients at high risk for exacerbation or under category C and D. Under long-acting are LABA and LAMA. LABA or long-acting inhaled beta-2 agonists. Clinical benefits of LABAs compared with short-acting bronchodilators include similar or superior improvements in lung functioning symptoms, as well as reduced exacerbation rates and need for hospitalization. LABAs are more convenient based on dosing frequency but may be more expensive. Next is LAMA or long-acting muscarinic antagonists. These are more selective than ipratropium at blocking important muscarinic receptors because they dissociate slowly from M3 receptors, resulting in prolonged bronchodilation with once or twice a day dosing. So when we evaluate exacerbation outcomes, LAMAs, primarily tiotropium, provide a greater reduction in exacerbation frequency compared to LABAs and should be considered as first-line monotherapy for patients at high risk for exacerbation. The next type of bronchodilator is combination anticholinergics and beta-2 agonists or dual bronchodilators. Combination regimens of bronchodilators are often used in the treatment of COPD as symptoms worsen over time. Combining bronchodilators with different mechanism of action allows the lowest possible effective doses to be used and reduces potential adverse effects from individual agents. Current clinical practice guidelines recommend combining long-acting bronchodilators for patients who have persistent symptoms or recurrent exacerbations on bronchodilator monotherapy. And then next type of bronchodilator is methylxanthines. This includes theophylline and aminophylline. Chronic theophylline used for patients with COPD may offer improvements in lung function and gas exchange. Theophylline has been shown to reduce dyspnea, increase exercise tolerance, and improve respiratory drive in COPD patients. Because of risk for drug interactions, significant intrapatient and interpatient variability in dosage requirements, theophylline therapy generally is considered for patients who are intolerant or unable to use an inhaled bronchodilator.
So the next one is the corticosteroids. The benefits of chronic system corticosteroid therapy in the chronic management of COPD are not clear and risk of toxicity is significant. Long-term adverse effects associated with systemic corticosteroid therapy include osteoporosis, muscular atrophy, thinning of the skin, development of cataracts, and adrenal suppression and insufficiency. Therefore, chronic therapy with oral steroids should be avoided in COPD patients. Currently, the recommended role of your inhaled corticosteroid therapy is for patients at high risk of exacerbation, primarily on the category C and D, who have recurrent exacerbations despite optimal therapy with inhaled bronchodilators. Next one is the combination therapy, which is the dual therapy with your LAMA or LABA or your inhaled corticosteroids with LABA. For patients with recurrent exacerbations despite optimal long-acting bronchodilator monotherapy, combination therapy with dual long-acting bronchodilators such as your long-acting muscarinic antagonist and your long-acting beta agonist is preferred over combination therapy with inhaled corticosteroids with your long-acting beta agonist. So the last one for the bronchodilators is the combination therapy, which is the triple therapy with your LAMA, LABA, and your inhaled corticosteroids. For patients with persistent symptoms and recurrent exacerbations on dual inhaled therapy, triple therapy with the LAMA, LABA, and inhaled corticosteroids is recommended as initial escalation therapy. Compared to dual therapy with either LAMA, LABA, or your inhaled corticosteroids with your LABA, triple therapy with LAMA, LABA, and inhaled corticosteroids provides additional benefit in reducing frequency of moderate to severe exacerbations in patients with COPD. The next pharmacologic option is your phosphodiesterase inhibitors. So your PDE4 or the phosphodiesterase 4 is the major phosphodiesterase found in airway smooth muscle cells and inflammatory cells and is responsible for degrading intracellular CAMP or CAMP. Inhibition of the phosphodiesterase 4 results in relaxation of the airway smooth muscle cells and decreased activity of inflammatory cells and mediators such as your tumor necrosis factor alpha and your interleukin 8. Roflumilast, which is an oral phosphodiesterase 4 inhibitor that is available in the US, is recommended for patients with recurrent exacerbations despite treatment with triple inhalation therapy. The major effects of the roflumilast include diarrhea, nausea, decreased appetite, weight loss, headache, and your neuropsychiatric effects such as suicidal thoughts, insomnia, anxiety, and new or worsened depression. The next pharmacologic option is azithromycin. In certain pulmonary conditions such as cystic fibrosis and bronchiectasis, chronic therapy with macrolide antibiotics, specifically azithromycin, has proven clinical benefit. Current guidelines recommend to only consider the addition of chronic azithromycins for patients with recurrent exacerbations despite optimal therapy and who are not active smokers. Next one would be your alpha-1 antitrypsin replacement therapy. For patients with inherited alpha-1 antitrypsin therapy deficiency-associated emphysema, treatment focuses on reduction of risk factors such as smoking, symptomatic treatment with bronchodilators, and augmentation therapy with replacement and alpha-1 antitrypsin therapy. Antitrypsin, sorry. Augmentation therapy can cost over $50,000 annually. In the absence of alternative treatments, it is difficult to assess the cost-effectiveness using conventional criteria. The alpha-1 antitrypsin replacement therapy is derived from pooled blood donors, and there have been repeated problems with the supply of this product because of the production and the contamination issues. So next one is the other pharmacologic options. The first one is expectorants and mucolytics. Compounded saturated solutions of potassium iodide, ammonium chloride, and acetylcysteine and guaifenesin have been evaluated as adjunctive therapy for patients with COPD. In 2011, FDA removed unapproved cough and cold preparations, including several containing guaifenesin from the market due to safety and efficacy concerns. Two extended-release tablets formulations are currently approved by the FDA, and other approved formulations of guaifenesin containing dextromethorphan or pseudoephedrine should not be used for COPD maintenance therapy.
Okay, so for other pharmacologic options, we have opioids. So systemic opioids, specifically those who are orally or parenterally administered, especially morphine, can relieve dyspnea for patients with end-stage COPD. So nebulized therapy is sometimes used in clinical practice, although data about its clinical benefit is lacking. And opioids should be used carefully if they are chosen to be used at all in order to avoid reducing the patient's ventilatory drive. So the ventilatory drive or respiratory drive is just the intensity of the output of the respiratory muscles of the patient. So it's their breathing effort. So if there's reduced ventilatory drive or reduced breathing effort, there would obviously be decreased oxygenation, which is not ideal for a patient who is already suffering from COPD. Next slide. Okay, and so for relevant information relevant to the case, related information, discharge preparation and follow-up. So prior to the discharge of the patient, we should assess for their medication adherence, their inhaler technique, if their pharmacotherapy is optimal, if they're ready to stop smoking, and also their immunization status. So in acute care or ambulatory care settings, clinical pharmacists are often called on to educate patients, recommend appropriate therapy changes, and assist patients with formulary or insurance barriers, as well as complete prior authorization requests. So there are dedicated programs that actually employ this technique in recently discharged patients, and it has actually shown a lot of improvements in terms of the patient's health outcomes after clinical pharmacists have intervened. So they've seen a reduced amount of readmissions in these patients when clinical pharmacy services have been used. So it's proven to be worth it, and it has shown the importance of clinical pharmacists in determining a patient's outcome. Next slide. Okay, so for this is the discharge planning and post-discharge follow-up in acute exacerbations of COPD. So it's a table found, I believe it's table 44-21 in DiPiro. So prior to discharge, we should assess the patient's maintenance therapy and optimize per therapeutic goals and patient factors, as well as assess the inhaler technique of the patient. So the plan to carry that out would be to ensure that the patient is able to obtain and afford their prescriptions for therapy. Obviously, if the patient can't, the patient cannot maintain and comply with their therapy if they can't afford it. As well as utilize motivational interviewing and teach back for education and counseling. Next would be to assess assess the technique and adherence before modifying the patient's therapy, and ensure that the patient understands their medications, which medications to continue or stop. So for example, for antibiotics, they should follow their antibiotic regimen completely. They should only discontinue the medication when they have been advised. They should not stop it earlier than listed on their prescription, as it encourages antibiotic resistance. Or for systemic corticosteroids, for example, we need to be clear that the patient cannot stop abruptly or too quickly, as they might have withdrawal symptoms or adverse effects and risks. There is a process to follow. So again, assess for tobacco cessation readiness if the patient has continued to smoke, and coordinate referral to outpatient tobacco cessation services if indicated. Also provide immunization while the patient is hospitalized. Then again, assess the immunization status of the patient, particularly with influenza and pneumococcal disease, and coordinate for outpatient services for supplemental oxygen if indicated. Assess the need for oxygen therapy after discharge, and assess needed follow-up for comorbidities. So the plan for that would be to ensure that follow-up care plans are communicated and the patient's appointments are scheduled, typically within 1 to 4 weeks after they've been discharged. Okay, so for 1 to 4 weeks post-discharge, we have to make sure to assess the symptoms of the patient. So this would be used using either the MMRC, the Modified Medical Research Council Dyspnea Scale, or the CAT score, which is the COPD assessment test. So the MMRC is basically just like a little self-rating scale that the patient will take just to kind of determine the level of disability that their breathlessness imposes on their daily life. It's a bit similar to the classes of heart failure. So for MMRC, it's a scale, or it's like a grade of 0 to 4. So 0 being, they don't really have any trouble except for when they have strenuous exercise and etc. And 4 being the worst, being, they can't even get dressed without being too breathless. They can barely walk out of the house or something. And for the COPD assessment test, it's just like a questionnaire that kind of determines the impact of the symptoms, on the overall health status of the patient. So for that, we have to ensure that obviously the patient completes the MMRC or CAT prior to or during their visit. We have to assess the patient's ability to cope in their usual environment and coordinate for home care services for assistance with daily living activities if the patient requires it, and ensure that the patient will be able to obtain and afford prescriptions for therapy. Assess the physical activity and ability to do activities of daily living. Assess the patient's inhaler technique. Assess the technique and adherence before modifying therapy. Again, assess tobacco cessation readiness if the patient has still continued to smoke. Assess the patient's immunizational status, and assess the continued need for oxygen therapy if oxygen therapy has been continued after discharge, and also assess the status of the patient's comorbidities. Next slide. Okay, so for 12 to 16 weeks post-discharge, again, we have to assess the symptoms of the patient using the MMRC or CAT score. Still assess the patient's ability to cope in their usual environment. Pretty much everything is the same except for now we assess the patient's airflow limitation through spirometry. So spirometry basically just kind of assesses the function of the patient's lung, their lung, their chest wall, their respiratory muscles, and their airways. So it measures the airflow going in and out of the patient's lungs. So how much air they inhale in and how much they exhale out, as well as how quickly they exhale. So the patient just kind of sits and breathes into the device and it records the values. It's pretty straightforward. And so yes, that would be the only thing that's different. We would still, assess the patient's inhaler technique, again, assess if they're ready to stop smoking, assess their immunization status, pretty much all the same, except the only thing that changes at 12 to 16 weeks is that they assess the airflow limitation. Next slide. Okay, so for evaluation of therapeutic outcomes, in chronic stable COPD, pulmonary function tests should be assessed annually, as well as also following any treatment additions or discontinuations. So take note if, for example, a drug is discontinued in the patient's therapy, even if it hasn't been 1 year, they still need to reassess the pulmonary function of the patient. It's also important to quantify and evaluate the patient's symptom scores, their quality of life assessments, and exacerbation rates, as well as their visits to the emergency department and hospitalization. Sorry. So we have to take into account all of these factors in order to determine if the patient's therapy is suitable and if their COPD is properly managed. During acute exacerbations of COPD, white blood cell count, vital signs, chest x-ray, dyspnea, sputum volume, and sputum purulin should all be assessed at the onset of exacerbation and throughout the treatment of the patient's exacerbation. In severe exacerbations, arterial blood gas and oxygen saturation should also be monitored. As with any drug therapy, adherence, adverse effects, and potential drug interaction should also be evaluated. So it's important to continue to explore strategies to improve the survival of our patients. And consideration should be given to these, outcome measures when initiating, continuing, and monitoring therapy. Okay, so for palliative care, end-of-life care, and hospice, so palliative care services can be recommended once the patient's symptoms have become very limiting or disabling, or if the patient has repeated hospitalizations occur in a short amount of time. So an effective strategy to discuss end-of-life care involves the patient's participation in identifying, their advanced directives and the goals of care. Palliative care is very, very patient-centered, so it's important that the patient is on board in order to, fulfill their wishes, and it's important that the patient understands, the benefit and the purpose of palliative care. It improves the quality of life of our patients who are, unfortunately at the end of their life. So it would be great if we had their participation in fulfilling what they would like to be done. In regards to pain management, the patient should be assured that it will be managed well and that their dignity will be preserved. And for the location and provider of terminal care, the desire to use or withhold mechanical ventilation, as well as involvement of family members in decisions on behalf of the patient, should be addressed. Okay, so that's it for our topic on COPD. Thank you guys for listening.